So if I can welcome to the stage now Brian, Luke and Ugochi to come. I'm going to do a very quick resume for those guys so that we can mainly kind of focus on getting on with the actual speaking. So Brian is a consultant in anaesthesia and critical care with me in Bradford, and he's also been a huge supporter of MEaCC regionally. You're going to hear him talking again later about education because he had a big focus on that as well. Luke Budworth is a researcher and data analyst at the Bradford Institute for Health Research and works within NIHR-funded Patient Safety Research Centre, which is the Yorkshire and Humber PSRC, and supports research teams in applying data science methods to healthcare data to improve safety outcomes. And Ugochi is a senior research fellow at the Bradford Institute for Health Research. Her team is funded by NIHR and is led by Dr. Jonathan Benn, who is based in the University of Leeds. I'll leave it there, guys. There's plenty more to say about all of you, but I want to listen to what you've all got to say. So thank you very much for being here today.
That's great. Thank you, Debbie. So I will kick us off. So we're looking at some of the data insights in the MEaCC, and I will start off by just introducing our research centre and talk about some of the goals of the study, the collaborative study that we're working on together, some of the progress we've made and some of the emerging results. I'll just try and... So, as Debbie said, Luke and I are based in the NIHR Patient Safety Research Collaboration in Yorkshire and Humber. It's one of 6 in England, and our centre is hosted by the Bradford Teaching Hospitals NHS Foundation Trust, and we are also partnered by University of Leeds and Bradford. And we work across diverse clinical settings with our clinical colleagues, working on applied research projects to improve patient safety. And we have 4 themes within our centre and an overarching cross-centre theme of safety and equity. So Luke and I are based in the Rethinking Safety Intelligence theme, and the MEaCC collaborative study that we're going to introduce to you today aligns with 2 of the sub-themes within the safety intelligence theme. So that's soft intelligence and integrated data. And we are partnered within the collaboration by our clinical colleagues in the MEaCC steering group, in the Improvement Academy, Yorkshire and Humber ARC, and then universities of Leeds, Bradford and York. So shall we skip this? Yeah. So you've heard quite a bit about MEaCC, but we've had one slide in, and Brian will take over.
Perfect. So as Viv and Lizzie have just outlined, all the data that we're presenting today has been captured through our MEaCC platform, and we're incredibly grateful to everyone who's collected data as well as Athera Insights for hosting that platform. One of the real challenges of this presentation has been trying to know what to leave out as much as what to put in. So I've really only been able to give you a snapshot of what the data looks like. And I've been focusing primarily on what in data science is referred to as descriptive data, which is the data that we're generally familiar with as clinicians. So these are the raw numbers with a bit of processing to really get a picture of where we are at a moment in time. And really the key questions that we've been looking to answer through the descriptive data are: which women become unwell and why do they become unwell? What level of care did the women receive? And that includes a bit of how deranged did their physiology become and what treatment did they end up requiring? What were the outcomes for mums and babies, not just in terms of hard outcomes like mortality, but also things like were mum and baby kept together wherever possible throughout the period of enhanced maternity care? and then looking a bit about, and this links in to the head of midwifery's question about what are the service impacts of delivering enhanced maternity care. And there's some caveats and limitations we need to consider with this data, in that although you'll see the word research because it's a research centre, this data has not been primarily designed as research. It's not randomised. There's no control group. There have not been any power calculations. So although we have got a number of statistically significant findings and associations, you'll notice that my slides don't really have much in the way of statistics on them. And ultimately, because there is our data is being collected in one region in the UK, and again we do see some discrepancy across which centres have contributed how much to the data. There is some potential for bias, although as our numbers get larger, the good thing is that that bias tends to reduce over time. So the data that I'm presenting today is essentially an amalgamation of 3 versions of the MEaCC database that's been exported and then has kindly been reassembled into a single document using a statistical program, and I'm incredibly grateful for our statistical support in that regard. And up until June 2024, we had 4,321 episodes of enhanced maternity care. That is pretty close to being 4,321 women who've required enhanced maternity care. One of the things you realise when you start collecting data is that you get better at it over time. So when we started, we didn't have any means of capturing if a woman had a subsequent episode of enhanced maternity care, or if she had a pregnancy where she had an episode of maternity care, completed that, and then got pregnant in the future and had a second episode of enhanced maternity care. But we know now that we've analysed our recent data, that only really occurs in a very small amount of cases. So, interesting things about age. Age is broadly normally distributed, looking at the curve, about what you'd expect. And again, BMI, we do see that there are some extremes of BMI that are represented in our data. But I think what's become clear is that actually the women who become unwell, it's not as easy as the moment they walk in the door, you'd just be able to identify them by a simple set of characteristics. And actually, that leads us into some of the modelling work that we're going to move on to with the data that Luke will outline later. We see relatively low levels of smoking, relatively low levels of substance misuse, and again, parity, most of our women are primiparous, and actually grand multiparous women actually don't contribute as much to the data set as you might expect, and are certainly not overrepresented in our hemorrhage statistics like you might well think at baseline. So one of the great things about collecting data at this scale is it confirms some of our existing biases, but it also confounds them. So thinking about which women become unwell, so most women, so the mean age at which a woman becomes unwell in pregnancy is towards the end. The most common comorbidities were mental health disorders, which has been mentioned previously in Anita's talk, diabetes, and if we add all diabetes together, that's probably about 10 to 12% of our women. Previous cervical surgery, which was interesting because I would not have necessarily picked that as a significant baseline risk factor, and respiratory disease, of which asthma is the most common. And interesting when we look at how the women deliver, some modes of delivery seem overrepresented in our data, and in particular the ones that stand out are assisted vaginal delivery and caesarean section following unsuccessful assisted vaginal delivery, and they seem to be a particular risk factor for hemorrhage that we see in our data. So which women become unwell? This is a really interesting thing because Embrace UK has had fairly consistent reports now showing that women from ethnic minorities, particularly Asian and women from black ethnic groups, are significantly overrepresented in their mortality data. And on our raw statistics, actually that wasn't necessarily the case, in that by far and away our most commonly affected group for becoming unwell are women from white British, white English and other white backgrounds. So we then looked at 4 of our centres, which we think probably had the most robust data in terms of numbers. And actually what we see confounds the Embrace UK data a bit, in that we see that in white women, which is the blue line, and in Asian or Asian British women, which is the orange line, broadly, EMC episodes occur at about a similar rate to which those women form part of the birthing population, i.e. if 50% of your women are white British, you'd expect 50% of your enhanced maternity care episodes to be in that group. Whereas interestingly, black women, and because the numbers get small when we subdivide our black population, we've had that together as a group. You can still see that there's about between a 1.8 to 2 times baseline risk of a black woman requiring enhanced maternity care. But going back a slide, what we now need to work out is, why are black women twice as likely to become unwell, but 4 times more likely to die? What happens in that process? Is this just a simple quirk of statistics? Well, as our data set gets bigger, we become more and more confident that this isn't just bias in the data collection. Is it something to do with systemic racism? Is it something to do with the models of care? Is it access to care? And in particular, do things like deprivation and socioeconomic status play as a more significant role? And one of the things that I'm really proud of moving into our latest set of data collection is that we've moved just from beyond collecting postcodes to actually being looking at indices of deprivation, and we'll be putting out some work hopefully towards the end of this year or early next year in that regard. Why did the women become unwell? Well, broadly, what we see in enhanced maternity care are the direct causes of maternal mortality, as Embrace UK would cause them, are significantly represented. So we know that over half our data set is women who've bled, we know that sepsis is a significant proportion, and we know that severe preeclampsia is a significant proportion. And that is interesting because there are women dying from things that aren't those conditions. So what it tells us is that women who die from a cardiac disease aren't necessarily going to come in through your maternity unit, present in labour and delivery and become unwell. They're likely to present in a different way, and what that means is that we need to put the woman at the centre and ultimately function as a team across services, so that whether women present to the emergency department, the acute medical department, a GP clinic, or indeed on the labour ward, we offer equity of access in that regard. And the other statistic to which Viv has alluded to before is about, so broadly, 75 to 80% of our episodes of EMC are associated with delivery. And we still need to do a bit of cause and effect work, because clearly if you develop sepsis and you get chorioamnionitis, that makes you more likely to go into labour. But likewise, we know that some of the episodes of enhanced maternity care arise directly from complications from birth. So the biggest single group in our population of data that we've studied so far is postpartum hemorrhage, of which we've got 2,225 women in this count, and that number has gone up significantly as we've continued to collect data. And to put that into context, the OBS Cymru study, which was the biggest study into bleeding in the UK, had about 2,900 women in that study. So we're starting to get to some quite large numbers. And there are some insights that we can develop from that, so we can still see that uterine atony plays a significant role, and we know that surgical injury plays a significant role. We know that women who develop tears to their broad ligament or damage to their uterine arteries bleed a significant amount. But we've also been able to model, if you can see in the top right-hand side of the screen, blood loss against your likelihood of requiring a transfusion. And broadly, once you get to beyond about 2.8 litres, it becomes more likely than not that you're going to have a blood transfusion. Now that's really interesting, because that completely confounds what I think of in clinical practice, in that I think most women who bleed more than a couple of litres probably end up getting some blood. So what we need to do is we'll drill down into that data in a subsequent paper, looking at what the outcomes were and how come there were some people who maybe had a 3.5, 4 litre bleed and didn't require blood, what their outcomes were in terms of their hemoglobin, but also some of the process outcomes and what drove that. And in particular, do we need to move away from simply measuring estimated blood loss in volume and actually measuring that per kilo and seeing whether actually do smaller women who lose a relatively small amount of blood actually lose a much proportionately larger volume, and that's why we see some of the discrepancies in the statistics. About a third of the women who developed a postpartum hemorrhage received a packed red cell transfusion, but the other blood products are really interesting in that we know from the Obs Cymru study and the work that's been done in Wales that fibrinogen is by far and away the blood component that is likely to become deficient in women who become coagulopathic in the setting of obstetric bleeding. And yet it's interesting that fresh frozen plasma is given more commonly than fibrinogen or cryoprecipitate. And what that suggests is perhaps we need a regional focus on hemorrhage, because I think part of what drives this is that we've only got a very low rate of point-of-care coagulation testing. So in our MEaCC database, where we've collected the data, only about 1.5% of women having a significant postpartum hemorrhage have point-of-care coagulation testing done. So there is probably scope for a postpartum hemorrhage bundle to be developed moving forwards. The other thing that's interesting and surprised me a little was the incidence of acute kidney injury in the obstetric population that becomes unwell. Now, in many ways, this is quite a poor way of measuring it. So this is using the Acute Kidney Injury Network or Kidney Disease Improving Global Outcomes criteria for acute kidney injury. This is not designed for women who are pregnant, and indeed, pregnant women have supranormal kidney function. So by the time you've developed even stage 1 acute kidney injury in pregnancy, you've taken some quite significant renal dysfunction. And we can see that that affects 10% of our women. What's interesting, and I'll come on to in another slide, is it's not really clear what the follow-up arrangements for that are. And we know from some of the preeclampsia work that actually if you develop significant preeclampsia in pregnancy, there is a lifetime cardiovascular risk that comes with that. And it's also feasible that if you develop an acute kidney injury around the time of requiring enhanced maternity care, that there might be a lifelong impact in terms of blood pressure and in terms of a proportion of these women developing renal dysfunction. If a better measure for acute kidney injury in pregnancy is using Weil's definition of a serum creatinine of more than 77 micromoles per litre. And what's really interesting is when we compare our 3 most common reasons for requiring enhanced maternity care, sepsis doesn't really seem to increase your chance of getting an acute kidney injury much. Postpartum hemorrhage does a bit, but severe preeclampsia really does significantly increase your chances of getting an acute kidney injury. Indeed, the probabilities are on the left-hand side, and you can see that it's your probability of getting acute kidney injury with severe preeclampsia is in the order of 30-35%, so that is significant. In terms of what level of care the women received, so broken this down into 2 bits. So one, what was the highest frequency of observations that the women required, and secondly, how long did they require those observations for? And some of this is to help gauge what is the service level impact in delivering care to these women. So we know that most of the women in our data set required observations either 15-minutely or more frequently, and most of the women required them for between 4 to 12 hours if they were having a postpartum hemorrhage, or up to sort of 24 hours in the majority of cases. Only a small proportion of our women required continuous monitoring, so about 5% of women in the study had an arterial line. And the big thing that we want to look at moving forwards is that we chose a really poor time to launch a big audit quality improvement project about 3 months before there was a global pandemic that disrupted healthcare services for a couple of years and is having ongoing legacy effects in terms of how we staff our maternity units. But actually, our rates of whether our staff have had specific training in delivering enhanced maternity care are lower than what we would like them to be. And this afternoon, I've got a talk where I'm going to outline some strategies in terms of how we can improve that. 167 of the women went to intensive care, which is about 4%, and the most common reasons for transfers outlined in Anita's talk, either for additional monitoring that can be delivered in the intensive care unit or for specific organ support. And I'm reassured to tell you that 83% of the women who went to intensive care had daily physical contact with their baby where that was feasible. And I think that that is a real success moving forwards, because as interested as I am in boring numbers and charts, actually the experience that the women have when they come to intensive care in our hospital, in a different building to where their baby goes, if their baby goes to neonatal intensive care, has a huge physical and psychological impact. This is another slide I'd like to focus on. So this is follow-up arrangements following enhanced maternity care. So we know that over half of the women who come in to and the reason why, I just want you to briefly look, it looks like we've been really crap at data collection on this, in that you'll see that there's a lot of missing data. The reason for that is this was a new question that was only added into the third version of the database. So much better to look at the valid percentages on the right-hand side. So we know that a majority of women who become seriously unwell spend longer in hospital, have some physical and psychological complications, but are then just plugged back into the system with routine community midwifery follow-up that is no different to someone who's come and had an uncomplicated vaginal birth with an expedited delivery. And I think the big thing that stands out from this is there's a real role for specialist midwifery clinics in terms of following up the women who become unwell, but also how we link into maternal medicine networks to pick up the complications like acute kidney injury moving forwards to modify the women's risk going into the future. So the service impacts of delivering enhanced maternity care are significant. The median duration of an episode of enhanced maternity care is 17 hours, and 95% of the women who required enhanced maternity care stayed within that labour ward setting, meaning that the resource to deliver enhanced maternity care needs to be delivered within maternity. And that has a knock-on effect for looking after those women. But has anyone been on a shift recently where there have been fewer than the expected number of midwives? So ultimately, we realise that there's not just an impact in terms of looking after the unwell people, it's also all the other people. Does it delay inductions coming down from the ward? Does it have an impact on whether you can start your elective caesarean section list on time? So all of these things are significant. Again, looking at the 4 units where we've got pretty robust data, we can see that somewhere between 6 and 12% of deliveries will require enhanced maternity care. And the takeaway point, if you're someone who is at service delivery, service organisational level, or indeed at national commissioning, is that if you're a moderately sized unit delivering 4,500 babies a year, you can expect around 400 women to require enhanced maternity care, making it predictable that on any given day, it is more likely than not that you will have a woman requiring enhanced maternity care, and indeed a midwifery and obstetric demand in terms of how that service is delivered. The good news is that the vast majority of women who become unwell during pregnancy improve with treatment, but unfortunately 7 women deteriorated and died from a whole variety of causes. There's not really any patterns we can draw from at this stage, particularly with such a small number. But it does highlight that, again, maternity services can't just work in silos, and there's the need to involve critical care outreach, critical care medicine as and when required. And I think the single biggest takeaway from this is that regardless of the number of women who become unwell, currently in the NHS there is no additional funding for providing enhanced maternity care, but we believe we've now got a set of metrics that means the development of a best practice tariff is feasible, and potentially the maternity incentive scheme might be the best way of delivering this. I'm just going to hand over to Luke now.
Hi everyone. So my name's Luke Budworth, and I'm, I guess, a statistician, which is kind of the old money term for a data scientist. So I've been leading some of the statistical analyses of the data. So I'll just go back to this slide. So in effect, there's three main tasks of data science. The first being, as Brian just showed, description, where we basically characterize the population that we sampled. So we can answer questions like what was the average age and the variance in age of the ill mothers in the sample. Obviously that's really useful, but what we want to do next really is go beyond that. It's such a large data set and a growing data set, so granular data, such a granular data set that it offers a real opportunity to conduct some really in-depth analyses and get some real insight. So beyond description, the second sort of main task of data science is causal inference. It's quite a difficult concept to explain quickly, but essentially it means that if we hold all factors constant, what is the difference between a mother with X characteristic versus Y characteristic on a given outcome? So for instance, what's the relative difference in sepsis probability if a mother's from a deprived area versus a non-deprived area, assuming age, ethnicity, so on and so forth, the same. So the main work I've done so far with the MEaCC data is actually a lot of the back-end stuff to sort of stitch all the different versions together and translate it from a raw data set into a more research analyzable data set. But we're beginning now to conduct some more of these in-depth analyses. So one of the things we want to look at from a causal inference perspective is beyond, obviously the Embrace report shows that mortality has been increasing, but beyond that, and it's really illustrated that there are inequities at the population level in mortality. But beyond that, we want to use the granularity of our data to be able to answer questions such as, if a mother becomes unwell and she's entered into MEaCC, what is the probability of that woman developing sepsis, for instance, and what are the differences between different ethnic groups or deprivation levels, so on and so forth. We want to characterize that at a more granular level. Because, of course, while the Embrace report is really useful and the statistics are great, it is at the population level. So that's something we're beginning to do now. But the main thrust of our statistical work has been around prediction. So prediction is simply training an algorithm to take as much historical information as possible and based upon that to produce probability outcomes. So, for instance, if a mother joined MEaCC, based on all the MEaCC variables, what's the probability of that one becoming more unwell? And you can sort of see straight away what some of the benefits of that may be. And of course, this overlaps slightly with MEaCC. So a woman could come in, and as you can see in the diagram, we could predict at the point of entry among mothers like her what probability the outcome may be. And if that is the case, if it's a high probability, then we have the opportunity to conduct sort of prophylactic, preventative interventions. I'm no expert on maternity care whatsoever, so I'll let other people do thinking about what those may be, but ultimately a probability statement about an outcome is useful. And those kind of models, of course, can be built into dashboards and platforms to assist clinical decision making. And that's just an example of what one could look like. And I'll just very quickly run you through a demo of a prediction model that we've run with the data. This is based on an older extract of the data, including about 1,000 mothers. It's based on just including a limited selection of variables, those on the left, so age, BMI, and just basic comorbidities. And we've looked at assessing those in a model, predicting a series of different outcomes, such as developing AKI, so on and so forth. But for the purpose of this, I'm just going to concentrate on number 8, which is any of the above. So, and just to say, in future modelling, when we run it with the bigger data set, the most up-to-date modern data set, it'll be about 5 times the size of the sample, and we'll look at different outcomes, including PPH and so on. So this is just a very basic example. If we use those variables to predict any bad outcome, in this instance using what's called gradient boosted decision trees, just with those limited selection of variables, we do seem to get fairly good accuracy. So 80% accuracy, meaning that our model classifies an adverse event occurring correctly 80% of the time. Although it's more complicated than that. There's lots and lots of different metrics that you can use to evaluate a model. And while our model here passes the threshold for the accuracy statistic, there's things like the false positive rate that could be improved. So we will do that. And one way we'll do that is to include more variables in our models. And one type of variable that we want to include in our model are contextual variables. So what is context? Contextual variables, what do I mean? I mean things like this. Everything else that's not this sort of clinical situation of the mother. Why do we want to add context into our models? One, because if context does predict or is associated in reality with outcomes, then it will improve the predictions of our models. But also because MEaCC and this have very different purposes and they're both useful. But one thing that risk prediction modelling can do that MEaCC can't in this instance is account for the fact that two mothers may have the same MEaCC score, but the context around them is completely different. So while in effect it could say the risk is identical, actually it's not, because one is in a situation which is more risky. So we can account for that in these models. And there's the beautiful thing about context, in theory, is that it's modifiable. So we can do something instantly about the risk, recalculate it, and see if it goes down. And of course, one of the points to make is that in our sort of exploratory demo modeling, if you rank the variables we've used in their ability to predict outcomes, by far, by a country mile, the most important factor is sight. What does that say to me? It says that there's something about the difference in sights or the context that means outcomes differ. But which contextual factors are most relevant? We don't really know. And how do we measure and capture them? Well, of course, one thing we would love to do is to be able to modify the data collection such that we do collect contextual information at the point when the rest of the data is inputted. But of course, there's more complications than that. So I will hand over now to Ugochi, who will talk about the phase of the project where we're trying to integrate our contextual factors into our modelling.
Thank you. So in our collaborative study, we're looking at contextual risk factors, and I'll talk about the qualitative phase. Luke's described some of the development of the risk prediction model, looking at maternal morbidity, using the MEaCC data. Stage 2 is the qualitative phase where we're reviewing the maternal adverse event reports from MNSI to identify any contextual factors involved in the adverse events. And stage 3 is where we're going to look at the models that Luke's developed and to enhance it with the identified contextual variables. So the MNSI, formerly HSIB, investigates patient safety incidents that are referred to them. The majority of them are for neonatal deaths, but we're concentrating on the maternal deaths where the MSI investigates where a mother has died during pregnancy or within 42 days after the end of pregnancy. In terms of the analytical approach that we'll be taking, we'll be concentrating on patients who received enhanced care on a maternity unit or critical care in response to deterioration. And we're hoping to examine the identification of deterioration and the response to it, as well as processes involved with clinical decision making. So far, we've categorized the cases and we've begun mapping the patient journeys, and we hope that this will enable us to then conduct a focused analysis of the contextual influences. So when we're talking about contextual factors, and Luke's mentioned them, we're looking at beyond risk factors that are beyond clinical data. So things that reflect issues around the socio-demographic status of the patient, environmental and institutional influences. So, for example, a patient's socio-economic status, their access to care, and anything like psychosocial support can significantly impact outcomes. And so we're hoping to identify that, as well as organisational factors like the staffing levels at the time of the incident, the workload, and any resource constraints that contributed to the overall risk landscape within the organisation. So where are we looking? We've already looked at NHS data to describe within our region, Yorkshire and Humber region, the maternity units. So we've gathered data on staffing, the size of the units, the number of births a year, the size and location of on-site HDUs and intensive care units. At the patient level, we're mapping the hospitalisations and the contact with healthcare in the preceding weeks and days before the maternal death, and we're trying to track where the contextual influences may emerge. And finally, with our qualitative analysis, we're going to look at the interaction of organisation and patient level factors to gain some insights into how decisions were made and how staff responded to the acute deterioration on the wards. So what have we found so far? The access to the MSI reports came through this summer, and it's taken us a while, but we've been able to categorise the cases into cases that could be included into the MEaCC audit, so there was a level of enhanced care or a transfer to ICU, and 9 cases met this criterion. And other cases where the mother came into the hospital and where possibly, because they're pregnant, maternity teams might have contributed to the patient care. So they came into the ED, majority of them. And then 18 cases meet this criterion. And majority of the cases are deaths that occurred in home or community settings and might have had some interaction with ambulance services, but most didn't. So what contextual factors are emerging? Majority of these are factors that we see in things like the Embrace report, but we're hoping to kind of look at, with the qualitative part of it, analysis, look at how they interact and how they contribute to the incidents and events that are part of the maternal death. So we've identified ethnicity and language as factors, even though they're anonymised, there are referrals to English not being the first language, or risk factors due to the patient's ethnicity. We've identified issues with staffing levels and issues with escalation protocols, the need for adequate training for midwives and junior clinicians, as well as transfers of care, so issues with transitions and handovers, and then some mention of hospital layouts. So with the thematic analysis, we're using a number of frameworks, and one of the main ones is SEEPS, which the MNSI report uses to structure the investigations and uses for the data analysis and to structure and write the reports. So SEEPS stands for the Systems Engineering Initiative for Patient Safety. It's an example of a framework that's used to investigate patient safety incidents using a systems approach. And that kind of approach and the use of those kind of frameworks helps investigators identify work system elements and conditions, and they can look at how they interact to result in an incident or an accident. So this helps to uncover deeper system-level causes of incidents and leads to more targeted corrective actions. So our approach will be to use SEEPS as the backbone and the elements of that framework to help us with our coding and theming of the investigation reports. So we plan to combine elements from SEEPS with complementary frameworks. So there's an example there of a framework used to investigate adverse events, and then other frameworks looking at the stages of clinical decision making. So we'll develop the codes and themes based on these, and then when we analyse, we'll kind of keep flexible in terms of adjusting or adding new themes that emerge from our data. And like I said, we hope that this helps us to uncover some systemic and individual factors in these adverse events reports, and help us with the identifying contextual factors to add to the risk prediction model. So as well as doing that, we're also looking to collaborate widely with our clinical experts. So we have clinical collaborators from the MEaCC who we're going to obtain some clinical reviews of the report. And then we hope to engage with patient experts at key stages when we're starting to identify the themes and contextual factors, and then when we finalise the themes for the predictive model. And we've already engaged with some collaborators from the Maternal Voices partnerships in our region. So we're hoping that this helps our findings be a little bit more enriched, and that they're based on around real-world experiences. So it's a bit small, but our next steps. Luke's mentioned the risk prediction model. This is looking at contextual risk factors, and then we're hoping to combine them and make our risk prediction model more valid. But we've still got some answers, some questions to answer. So what contextual factors are important to use? How can we measure them? How can we incorporate them into the model? And ultimately, how can we validate the model going forward? And what are the ways to update it with when new data comes in? So watch this space for some of that. And thank you very much.